Hi everyone. My name is Sakina Alston, and I am a student. I'm a master's student, a master's of nursing student at ECPI University, and myself and my classmates are in a nursing theories class, a multidisciplinary approach. It's nursing 511, and it's instructor Martha Colvin, and we are doing Unit 3's XP points assignments, and we are to discuss nursing theorists, their theories, and how we would apply them to our practice. So I'm going to go first, and then my peers will introduce themselves. So the main nursing that I do right now is peds emergency room nursing, and sorry that I'm not looking at the screen, but I've got these notes here. So one theory that is very helpful to me in the pediatric emergency room comes from the behavioral sciences, and it's Erik Erikson's psychosocial development theory. And that theory covers all the stages of life from birth to death, and in every stage there are specific goals that are to be met by each person, and they go in chronological order, but everyone goes at their own pace. And the reason why those help me in practice is because I really have patients from the day they're born until, well, at least 18, and sometimes we pull older patients. And because I'm just meeting them for the first time that day, it helps me to know what stage they should be in. So I can compare what stage they should be in to what they should be accomplishing in life. And then it helps me to come up with nursing diagnoses that they might have, and it also helps me to come up with implementations or interventions that I can do to help them get to that goal. Like one day I was with a 9-month-old, and that 9-month-old was not sitting up and couldn't pull up. That's not a specific stage of his theory, but going by the basis of what milestones you should be meeting, I knew that that child had a problem that I could investigate. Sometimes I know a problem before the parents even know a problem, because they don't know what developmental stage the child is supposed to be at. So it's just helpful because it helps me when I meet a person for a very short amount of time to know what stage they're in, so I can plan and evaluate if they've met that stage. So that's the behavioral theory. Then there's a theory from sociology, which is the critical social theory. And I really, really like this theory, and I hope that it gets explored more, because it can help with public health issues. So the critical social theory started with Marx, and he said that oppression requires revolution. So the critical social theory, it says that, that certain groups in society, like cultures, are in a predicament where they're oppressed for a certain reason, like as groups. I can give an example that in some neighborhoods there's more liquor stores than there are pharmacies and grocery stores put together. So the critical social theory says enlighten people about the disparities that they're facing, so that they can make changes to empower themselves and free themselves from that kind of oppression. So if I was in the city where there was more liquor stores than there were grocery stores and pharmacies, and I'm in pain, maybe I will treat myself with whiskey to get rid of the pain, because that's what's available to me. But if I'm made aware of what's going on in the situation that I'm living under, maybe I could plant some healing herbs on my back porch. I've seen people do that in Philadelphia. So then they would have those herbs to go to where they could make concoctions to try to heal themselves when they're sick. And so that, I think that's really, really important nowadays, because we need to take our health into our own hands, because the healthcare system is having a lot of issues, and a lot of people can't afford it and they don't have access to it. So critical social theory says let people know what situation they're in so they can gain knowledge and change what they're doing so they can free themselves. So I really like that one. Then there's the health belief model, which is a behavioral theory that says if we have to change the thinking of a person in order to change their behaviors. So people they behave, as far as health, they respond to their perceived threat. So if a person if a person's parents smoke and they see the parents is fine and well, they would say, well, my dad smokes and he doesn't have cancer, so I'm going to smoke. So you change the thinking. You give them some education and you teach them how cigarettes affect their body and how it can give them cancer. Change the thinking away from that is not a threat to me because I know someone that smokes and doesn't have cancer, so that they can realize the threat and then they will not smoke because they perceive the threat. And I think that the health belief model, which is a behavioral theory, follows up very well with the critical social theory, which is a sociology theory. Okay, so that's all for that one. And then one last theory is Dorothy Johnson's behavioral health system. I really like that one. And that system is a grand nursing theory, and I had to include that because I needed to talk at least about one nursing theory. And it says that a human being is a system of behaviors. And there are different systems that we have a scope of behaviors for. And the reason for this theory is to define the function of nursing. And what it says is that nursing helps to manipulate people's behaviors when they are not exhibiting behaviors that protect or promote their health. So one of the behavioral subsystems is the elimination subsystem. So if a person is constipated, but that person doesn't drink water and doesn't eat vegetables, then they get constipated. So the nurse would come in and teach the person how to drink water and to eat vegetables, and then maybe they won't be constipated, or to exercise or whatever. So that's what that theory does. So the reason why I like that one is because it's very helpful in coming up with nursing diagnoses as well as interventions, and then you can turn around and evaluate whether the intervention worked, because you will know whether the behavior that the person is now exhibiting supports the goal of the behavioral system that you're looking at. It would also help you to give a clear report to the next nurse, because it helps you explain what's not getting done, why this is affecting the health, and what we're working on, like the care plan. So I know that was a lot, but that's all I got.
Okay, I'm going to go next. My name is Christine Coleman. I'm going to discuss Dorothy Orum's theory of self-care. This one's important to me. I still work the floor. I'm a surgical nurse, so when I get patients post-op, a lot of times they start with the beginning of the self-care model, which is maintenance of sufficient intake of air. They're always on oxygen. We're always trying to get them back O2 stats up, things like that. And then it continues from there. So by the time that they leave my unit, they should be walking, and although in some pain usually, they should almost be where they were to begin with. You know, our goals are specifically arranged around getting the patients from surgery through ambulation, getting them off IV fluids, getting them off O2, feeding themselves, dressing themselves, all those kinds of things. Some are, of course, quicker than others. Some are only there for 1 night. Some are there for 4 or 5 nights, and unfortunately sometimes longer than that, usually the older they are. With her theory, any deficit in a self-care model that's present, the nurse should be assisting with, and that's the nurse or the nursing assistant, or somebody should be assisting them with their own their care, be it ADLs, making sure their pain is adequately controlled, making sure they get up every day. The other things she discusses in her theory are, I told you, intake of air, intake of water, sufficient intake of food, provision of care associated with elimination process and excrement. Particularly on my unit, that is an issue. We have a lot of GI surgery, a lot of resections and things like that. You know, I do a little dance the first time my patients pass gas. It's a big event. Maintenance of a balance between solitude and social interaction, prevention of hazards to human life and human functioning and human well-being, the promotion of human functioning and development within social groups. That's a little bit more advanced than I usually do on my unit, but certainly we don't really have visiting hours in my hospital. We encourage family members to spend as much time as they can. We also encourage them to participate in the care, meaning that they can actually be part of this self-care model and assisting the patient. Dorothy Orum's, her implementation is acting or doing for another, guiding or directing, supporting, providing an environment that supports development, and then teaching. So teaching the patient to care for themselves once they go home. For me, that's part of our discharge instructions, making sure that they know what they need to do to take care of themselves. Sometimes that's home health care, making sure that gets arranged, or making sure they know who to call if they do have a problem, when they need to go to the emergency room for, if there's fever, if there's drainage, all that kind of stuff. Making sure they have all the tools that they need to continue to take care of themselves at home. And that's really how Dorothy Orum's theory of self-care applies to my position on the surgical unit.
Okay, my name is Viola Pierce, and I will go over Maslow's theory. So instead of the way that Maslow his focus was not on the frailties of people, not on the things that they can't do, but rather on the things that people can do. If he focused on the full potential of people. Motivation is the key to his theory, and the individual is an active participant, and also there's 6 stages to his theory. The 6 stages are physiologic needs, which is at the bottom, so that's the base. So if they're hungry or if they're thirsty, then they can't think about anything else other than what's going on within their safety needs. The love and belonging needs, self-esteem needs, self-actualization, and then self-transcendent needs. And so as a shift supervisor in the emergency room, it's pretty hard to a lot of times have, and this is how it applies to me in the emergency room, is that, in order to motivate people to, do the things that they should do, or motivate nurses to do the things that they should do, first we got to meet their physiologic needs. So we have to make sure that they have, lunch breaks, and that they are able to eat, and that their safety needs are met. So, if we have a GSW that comes into the back door, then we have to make sure that the nurses are safe. So we'll place it, we place the ER on lockdown. Love and belongings, whenever they come in, we have a good word to say to them. I try to always speak to them very nicely. I always try to be very good to the nurses. Smile at them. We set the tone for the day. And we just need to emphasize the strength of each of the nurses. And then the nurses can pass it on down to the patients. So if your nurses are happy, then your patients are happy a lot of times. And then, transcendent, it goes from physiologic needs on up to transcendent needs, which goes above and beyond the range of normal or merely physical human experience. So, they go from self-actualization to that self-transcendent stage. And then the motivational theory, which is sort of the same theory, but it focuses on the factors that enhance employee satisfaction. So it's the same theory. It's just, it applies directly to your employee satisfaction, and factors that negatively impact. Also, you focus on those factors that are positive for your employee satisfaction, and you also focus on the negative, and you study them both, and you try to eliminate the negative, and you try to enhance the positive. And so those were my 2 theories that I came from. Thank you.
Hi, I'm Christina Bullock, and I am going to only present two. The first is Roy's adaptation model, which is about adaptation over a lifetime to every situation. Callista Roy, in the meta paradigm of nursing, coins that there are 4 adaptive modes of this, and physiologic and self-concept, role function, and interdependence. Out of those 4, the most important, as a acute care nurse here in a hospital, that I'm dealing with acute patients that are sick, and I don't know what happens to them after I care for them, but while they're in my care, I'm going to be thinking about their physiological mode. I'm going to be taking care of the physical. I put in lines, I do advanced lines and PICC lines, and I'm thinking always about, are their labs well? You know, what's going on with their labs? How is that integrating in? Are they adapting to that? If their creatinine's getting higher, then their kidneys are not adapting, and the medications should help, but sometimes it doesn't. So it's all about adapting to the stressors and how they're going to pull through. And my job as a nurse is to constantly think about what's the next. If we're going to do this to a patient, then what's the cause and effect after? Is the patient going to adapt to it? Callista Roy, when she wrote this in the 70s, late 60s, didn't have all the technology that we have today, and so it's greatly still relevant to this day. It's amazing how relevant this theory still is, just like Nightingale's theories are still relevant, because it speaks to the caring of a patient and the care they receive. Callista Roy is still alive today. Just an off note here, because I'm only doing 2. She still speaks today, and she's still on faculty today, and she is greatly in her 80s, and she's an amazing woman. Going on to the other theory, which is a sociological theory, and one that is quite relevant, the chaos theory. I found this very amazing, how that I could just take everything and extrapolate these items and make them all fit into what I do as a IV nurse. The chaos theory and how it comes into this meta paradigm is that things are not random and haphazard, but on a nonlinear level, many things are going on. And in this nonlinear level, if one little tiny thing is changed on one level, it's going to affect the whole. And the butterfly effect, of course, is a very well-known coin phrase, or little idiom that we say all the time. Well, this butterfly effect is very important. If someone's not going to be compliant with their diabetic medication, it's not going to be out of the realm of possibility that they're going to have a BKA or an AKA down the road. If they would have taken that medication, that outcome would be different. In my line of work, if people don't scrub the hub of a central venous catheter and vigorously clean that before they attach things to it, they're not going to get a CLABSI, which is a central line associated bloodstream infection. So 75,000 people every year are going to die because of those, and they're usually the very young and the very old. So I want to make sure that my little butterfly effect with this chaos theory is that I'm teaching these nurses how to care for these lines so that the patients have the better outcomes and the optimal outcomes for them. So that is, in a nutshell, what I wanted to say about the 2. And I think this completes our time together, and Google on air, Hangouts, whatever. And does anybody have anything else that they'd like to say or add?
I just want to say thanks, and I've learned a lot from you guys.
Yeah, this was great.
I've learned a lot. All right.
All right.
Sakina, are you in charge? Are you driving?